So we will understand hypersensitivity reactions very rapidly. So type 1 hypersensitivity reaction, what happens if an allergens come and it acts on our APC? It is an antigen presenting cell, and this APC presents our antigen to the cell Th2 type of cells, which are mediator of immunity, and they tell that B cells come and produce IgM, class change it to IgE. So IgE type of antibody will cause the type 1 hypersensitivity reaction. How? This is the first exposure. In first exposure, there will be sensitization. That is, the mediator of immunization will remember that there is an antigen X which is not dangerous otherwise, but our immune system wrongly considers it dangerous. And on second exposure of this antigen, it will activate the B cell again, and this B cell will produce IgE, and this IgE will attach on the mast cell on which there are receptor for Fc portion of IgE, and IgE antibodies are attached to it, which are specific to some antigen. So an allergen will come, and this allergen will bind to these IgE antibodies, and due to this, there is deformity in the membrane of the mast cell, and the granules of the mast cells get released. One of the most important component of the granules of the mast cell is histamine, which leads to this. In this picture, you can see there is a boy and there is edema. So histamine leads to edema because of increased vascular permeability, and it also leads to vasodilation, resulting in red rash edema, which can be periorbital and can also involve larynx, which can lead to respiratory failure. Vasodilation part can result in decreased falling BP. Now understand, hypotension is not a necessary criterion for diagnosis of anaphylaxis. Bronchoconstriction due to effect of histamine can also be present along with skin manifestations. I've written in number 1. Bronchoconstriction can lead to wheezing, difficulty in breathing. Sensation of choking, etc. is due to effect on the larynx. Treatment of anaphylaxis is adrenaline IM while given at 1:1000 dilution, which is the dilution of the vial itself. We don't have to dilute. And the dose is this. Understand, type 2 hypersensitivity reaction, in which we have immunoglobulins which attack a fixed antigen. So we have one immunoglobulin attaching on one antigen. So these one comes together. This one and this one comes together to make type 2 hypersensitivity reaction. One of the most classical example of it is Cook-Pasteur syndrome. There is formation of antibody against the collagen 4. Now understand, an antigen which is circulating, many antibodies attack on it. So there is one antigen and many antibodies, which is type 3 hypersensitivity reaction. One of the most classical example is SLE, presenting with rash and arthritis. So these immunocomplexes will deposit on many organs, most classically kidney and blood vessels. Biggest exception for this is Crohn's syndrome. Rarely involves the kidney. And effect on blood vessel, there is fibrinoid necrosis. Highlighter pink. Now understand, cell mediated hypersensitivity type 4. There are histiocytes which are macrophages, and these macrophages are there because these lymphocytes, which are actually Th1 cells, are activated, causing release of IL-1 and IFN gamma, which is important for the recruitment of macrophages. These macrophages get recruited and they will release IL-12, which will stimulate Th1 to release even more IFN gamma, and so on. So a vicious cycle is made. There are caseating and non-caseating granulomas. There are multiple examples for both of them, but the classical examples are, for caseating granuloma, this is TB, and for non-caseating granulomas, we have Crohn's and sarcoidosis. In TB, we have Langhans giant cells, and in sarcoidosis, we have asteroid bodies